Good morning. Good morning. All right. I am Terry Peterson, a Roosevelt University graduate and current trustee, and also Vice President of Government Affairs at Rush University Medical Center. On behalf of the trustees and the alumni at Roosevelt, I welcome you to the Blue Cross Blue Shield of Illinois panel discussion on healthcare in America. As we talk this week about the American dream, we recognize that healthcare and its future for all Americans is one of the most important issues before us today. Our speakers will bring a variety of perspectives on this important topic, and afterwards we look forward to your questions. I would now like to introduce Dean Melissa Hogan from our College of Pharmacy, who will moderate our discussion today and introduce today's speakers. Again, welcome and thank you for being here.
Thank you, Terry, and welcome to our panel discussion. We're here to explore the link between healthcare and the pursuit of the American dream. And before we begin, I'd like to recognize and thank Blue Cross Blue Shield of Illinois for sponsoring this session and our conference for the second year, and to our alumnus and trustee, Maurice Smith, for his support. The United Nations Universal Declaration of Human Rights states that everyone has a right to a standard of living adequate for health and well-being of himself and of his family, including medical care. However, a large number of Americans have not had access to quality, affordable care. Thus, an essential question for all Americans is whether we agree that such care is a right or whether we believe it's a privilege. Although the U.S. enjoys great technical advances in diagnostics, surgical techniques, genetic engineering, and drug therapy, our spending on healthcare does not translate into better outcomes. In 2014, the United States spent $9,400 per capita on healthcare. By contrast, the European Union collectively spent $3,600 per capita, and Canada spent $5,300 per capita. So despite our tremendous investment in healthcare, the U.S. ranked 31st in the world in 2015 for life expectancy, far below many nations that invest much less than we do. Within the U.S., health disparities lead to wide gaps in mortality rates based on education, gender, race, and socioeconomic status. The Patient Protection and Affordable Care Act went into law in 2010 and provided numerous health policy reforms designed to improve access to and quality of health care. The elimination of this act was a central focus of the Republican Party in the 2016 presidential election. However, despite a current majority in the House and Senate, the Republican Party failed to repeal or replace this act. Efforts are now underway to work through committee to change the legislation. What will happen to health policy in the U.S. is impossible to predict, but what is certain is that Americans' expectations for health coverage have been altered because of the Affordable Care Act. It is within this new landscape that lawmakers must now work. The best part of this act is also the best known part of this act is also the most controversial. The Affordable Care Act requires that all Americans have health insurance or pay a penalty. It has several provisions to this end. It allows parents to insure children up to the age of 26. It eliminated pre-existing conditions clauses as a means to delay or deny health care. It allows states to expand Medicaid coverage. It requires employers with 50 or more full-time employees to offer health insurance. And it requires individuals without insurance to purchase it through the marketplaces with subsidies offered to lower-income individuals and families. Because of these provisions and because of the economic recovery, which increased the number of people in the workplace, the number of uninsured has dropped significantly. The Affordable Care Act also sought to improve health quality and outcomes. It requires all plans to offer certain preventative services free of charge. It encourages employers to provide wellness programs, and it includes penalties to hospitals if Medicare patients with certain diagnoses are readmitted within 30 days. And it established the concept of medical home, in which patients receive coordinated health care services from an interdisciplinary team. Many questions remain regarding the impact of the Affordable Care Act and the best way to reduce health disparities. And we'll turn to our panelists to discuss the challenges and opportunities for improving health care in America. Today, we're joined by three individuals with tremendous amount of clinical experience and health policy expertise. Dr. James Madera, MD, is CEO of the American Medical Association. His career began with 20-plus years at Harvard, where he received clinical and research training, served as a tenured professor of pathology, and was director of NIH-sponsored Harvard Digestive Disease Center. After 5 years as chair of pathology at Emory, Madera served as the Thompson Distinguished Service Professor and Dean of the University of Chicago Pritzker School of Medicine, and as CEO of the University of Chicago Hospitals. Along with his current position, Madera is chairman of Health 2047, a San Francisco-based design firm whose mission is to help advance the AMA's goal of improving health of the nation through innovative solutions. Please welcome Dr. Madera. Eric Zimmerman is a partner at McDermott, Will, and Emery, and president of the American Health Lawyers Association. He is an authority in Medicare law and policy and is a registered lobbyist who represents clients before Congress and administrative agencies and helps clients navigate federal, legislative, and regulatory processes related to Medicare coverage, coding, reimbursement, and compliance. He primarily counsels and represents hospitals and health systems, ambulatory surgery centers, clinical laboratories, pharmaceutical, biotechnology, and device manufacturers and suppliers, medical trade associations, and professional societies. Zimmerman is partner in charge of the firm's Washington, D.C. Health Industry Advisory Practice, and he also serves as principal of McDermott Plus Consulting, LLC. He earned his JD at George Mason University School of Law and his MBA at George Washington University. Let's welcome Mr. Zimmerman. Maurice Smith is president of Blue Cross Blue Shield of Illinois. He's responsible for all Blue Cross and Blue Shield Illinois operations, including sales and account management, provider network contracting, medical management, government relations, and public affairs. Before assuming his current position in 2015, Smith led Healthcare Service Corporation Treasury Department and corporate development initiatives, including mergers, acquisitions, and the formation of strategic partnerships, and was focused on the key role capital deployment plays in corporate strategy. Previously, he served as vice president, corporate transactions and business analysis, with responsibility for negotiating various mergers and acquisitions, strategic relationships, as well as corporate financial forecasting. Smith holds a bachelor's degree in business administration with a concentration in accounting from Roosevelt University in Chicago, Illinois. Let's welcome Mr. Smith. Before we get started with our questions, I just have a couple questions for you. I want to know who's in our audience. So can all the students here raise their hands? Welcome. How many of you are future pharmacy students? Any healthcare providers in the audience? Anyone who works for healthcare insurance? And who here has no background in healthcare or health policy? Awesome. Thank you all for joining us. So now I'm going to ask our panelists a series of questions aimed at addressing the different aspects of healthcare in the U.S. And I think their different backgrounds and experiences will provide a broad perspective on the issues and generate an interesting conversation. We'll save time at the end for discussion with the audience. So we'll start with a question for all the panelists. I'd like to know how you see the topic of healthcare fitting within the concept of the American dream.
Well, I'll tell you, one thing that we know about insurance coverage in healthcare is that if you're not covered, you live sicker and you die younger, and that doesn't comport with a dream.
I'll add on to that if you define the American dream as equal opportunity to prosperity, as Dr. Madera said, there's plenty of evidence out there that suggests that those with health insurance are healthier, have more financial and economic success, and those without certainly struggle. And if, again, you're defining the American dream as equal opportunity, if children are too sick to learn, if adults are too sick to work and do not have equal access to health services, then there's going to be a certain drag on their ability to achieve on that dream.
And both of you said it well. I would just tell you, just personally, just growing up without it, I can tell you what it means to have a healthy life and a healthy stability. If you're healthier and you feel like you have access to health care, the stability that you gain from that, both mentally, financially, emotionally, is, it's profound.
Thank you. So let's go a little broader. When it comes to influence, what role do companies, in particular your companies, play in getting to a better place in delivering health care? Do you want to start, Maurice?
Sure. So as you know, we are a health insurance company, so our principal goal is to ensure access to coverage to health care. We see ourselves as an important piece of organizing the system of health care. We are certainly critical in terms of providing choice to consumers. We see ourselves as advocates for our members in all material aspects, from the provider to the pharmacy to just general community issues. So we see ourselves as the major organizer of the system, an important piece of that. But obviously, those who deliver the health care are central key partners to us in every regard.
I'll just chime in quickly, Melissa, and say that you mentioned a number of statistics in your opening about how much we as a country spend on health care and the result of those expenditures, whether we're actually getting a lot for our money. And one thing that I've learned in my years of doing this is, I think as Americans, we're fond of saying we have the best healthcare system in the world, but if the statistics don't really bear that out. And I think what we have are some of the greatest medical institutions in the world and some of the greatest healthcare technology. But when you look at it systemically, it's not really a system. And when you ask the question about the role of companies in fulfilling on that American dream, we have employer-sponsored health insurance as a historic artifact of how the system has sort of evolved, but clearly it's left some gaps. Not everybody worked for a company that offers insurance or is employed. And so government has stepped in and stepped in more increasingly in the last decade to fill those gaps, but clearly companies and employers can only do so much with respect to providing health insurance.
At the AMA, our mission for 170 years has been to promote the art and science of medicine and the betterment of public health. And we've had shifting areas of focus during that 170 years. So the end of the 19th century was stamping out quackery in this country that was rampant. The beginning of the 20th century was reorganizing medical education, so it was more university-based. And I think now one of the aspects that we have to tackle is what Eric referred to as this non-system system, this fragmented system. To deal with that, we kicked off and opened an innovation studio in Silicon Valley in January of 2016. And the topics there that are dealt with include topics such as data liquidity. We can't transfer data, clinical data, in an organized way cheaply. If you look at most multi-sided markets, as healthcare is, they all have a central utility, such as the SWIFT system for international currency exchange, the electrical grid, the internet. Health doesn't have that. And so when we think the lifeblood of health today, it's data. And we have to have a central utility that's affordable, useful, and connected, That's one of the things that we're working on. One point I want to make about the data. It is true that among the OECD nations, this organization of largely developed nations in the world that share data, if you look at the expense of healthcare in the United States, it's far above per capita what it is in the other countries. What is less talked about is if you look at the same set of data and you look at safety net support, including nutrition, early childhood education, housing, United States is dead last per capita. And if you look at a blend of those, we're kind of in the middle. And so we take a unique view of healthcare in the United States. You can think of it as kind of a pyramid where the base is early childhood development, nutrition, education, and housing, and the peak is the most complex neurosurgery you can imagine. Other countries like the UK, they do restrict what happens at the top. There is rationing. In the UK, if you're a certain age, you're not going to get a kidney transplant. This country, among the insured, pretends that we don't ration, but we actually ration at the base of the pyramid in early childhood development, nutrition, and the safety net programs.
So how can we change the conversation?
Well, one thing is to be attentive to that and recognize that about 80% of the $3.4 trillion we spend per year goes toward chronic disease. And much of that chronic disease has societal, behavioral aspects to it, things that aren't particularly effectively. In fact, I think physicians have proven those things are poorly handled in physicians' offices. And so thinking about connected technology approaches, we have, for example, launched with the CDC a program for diabetes prevention. We've shown it to be effective. It requires counseling. We're working with Intermountain Health in Utah to now compare virtual programs with coach-based programs. Our other focus in chronic disease is hypertension. We've created a series of tools, applied them in pilots in South Carolina, and shown that we can increase hypertensive control in a way that would predict a third less stroke and cardiovascular accidents. And we now have a formalized partnership with the American Heart Association that we just launched. We're just beginning to recruit, but already we have over 1,000 institutions covering over 14 million lives with 3 million hypertensives in it. And our goal there is that, hypertension in the United States, probably about 80 million people, only about 40 million are controlled. It's the #1 killer. And many of those 40 million know they have hypertension or are seeing a provider, and yet they still have hypertension. And that's one of the areas we're wrestling with now. So I think in the last half century, we've shifted dramatically from acute disease to chronic disease, but our system, our education, we're set up still in this fragmented way as though we're dealing with acute disease, and we're actually not.
So, Eric, I'm going to ask you this question first. There's a lot that all of you and your organizations are doing in terms of health policy and providing care, trying to improve things for the public. What should individuals be doing? How can they get more educated, more vocal, both in terms of policy and in terms of their own care?
Well, I'll speak to the policy aspect of it and say that I think we actually have pretty remarkable civic engagement at the moment right now on the healthcare debate. And going back to your question before about how do we change the conversation, actually there has been a really robust conversation in this country. I mean, you could argue for decades, but at least for the last decade, about healthcare. It is clearly such a substantial part of the economy, as well as a fundamental part of, again, achieving on the American dream. And we're wrestling with how to resolve these problems, how to improve upon the system here in this country. And as I said, there is a remarkable level of civic engagement. You see it in the town hall meetings. Of course, we have a lot of jerking to the right and jerking to the left. 8 years ago, when it was the debate around the Affordable Care Act, you had people from the more conservative end of the spectrum showing up at congressional town hall meetings and urging, to put it politely, their legislators not to enact the Affordable Care Act. Now you've got people from the more left side of the spectrum showing up at congressional town hall meetings and urging their legislators not to repeal the Affordable Care Act. So there's clearly a lack of resolution or consensus around what the right answers are, but I think that individuals are engaging in the conversation and should continue to do so.
Yeah, and I just add to that, just get involved. I mean, there's a lot of literature out there coming from both angles. As you know, some are great supporters of what's going on now. Others have an alternative view to that. But, get to the base facts, at least as they relate to you, and then get involved. Be a part of the national conversation. And that means getting the facts. That means asking the questions. That means, if you think it's important to you enough, working with your congressional leaders in your particular state. So getting involved is just a key. But becoming aware of what are the facts is critically important. So you know what you're advocating for or against.
So this may be an obvious question, but I think it's an important one. Can we talk about why there's such a partisan divide and even a divide within parties around healthcare?
I'm sorry, Melissa, say
Why there's such a partisan divide and then also a divide within parties, as we've seen around healthcare?
Yeah, I'll take a first stab at that. One of the reasons why I've been pointing to why the Republican effort to repeal the ACA collapsed, and there are many reasons, is because people can say Democrats are from Venus, but Republicans are from Mars, Saturn, and Pluto. And I think it illustrates your point, Melissa, that there is, it's hard to find consensus even within the parties. And a fundamental reason why Republicans failed, at least to this point, to repeal the ACA is because they didn't have an alternative plan of their own. They found themselves in November all of a sudden holding the reins of power in the executive branch as well as Congress, and a pressure to fulfill on their promise to repeal the ACA. And they started the debate with a conversation about just repealing the ACA, and that quickly went sideways when some more reasonable senators and representatives said, well, what's the replacement plan? We have to replace it with something. We can't just repeal the ACA. And then it became immediately apparent that they did not have consensus around a replacement plan, and they hastily tried to assemble one. And I don't say that to be critical of Republicans. I could say the same thing about Democrats, who are now in the role of obstruction in Congress trying to thwart repeal of the ACA, yet you don't see a consensus Democratic position either on what is necessary to fix the ACA. Stuff, as the title of the talk says, is all very complicated. And we're talking about a major entitlement program. I don't think everybody fully appreciates that the ACA really is a new federal entitlement like Social Security, Medicare, Medicaid. And whether we want to put government, the federal government in particular, in that central role of providing health care or enabling health care. I think there's also a misnomer about whether this is government health care or not, but we'll save that for another question. Put government in the central role of enabling access to health insurance and health services. That's a real, genuine debate, and we have to wrestle with that as a country.
One thing that I would add into that is this notion put forward by a fellow named Balmore, who recently passed away, called the cost disease. And what was recognized, he began studying symphony and was really interested in the fact that it was a difficult economy to keep a symphony going. And it required sometimes local government support, a lot of philanthropy. So what was the economic basis of this? And what he learned was that there are areas in society, industries in society, where there hasn't been increased efficiencies. So if it took 8 minutes to play a violin concerto of a particular type a century ago, it's kind of unreasonable to expect the violinist to do that in 4 minutes. And there are 3 domains that exhibit this cost disease: healthcare, education, and the arts. And these 3 domains often require support from the outside, for example, support such as government support. So that's one argument, saying that in a society, until the industry wrestles down to this problem of efficiency. And the way it's been wrestled down to the ground in medicine is sort of the opposite of what you would expect. We did a 5-state study in collaboration with Dartmouth, where we did a time motion study, watching how physicians actually spend their time. For every hour face-to-face with a patient, a physician spent 2 hours on data entry and clerical work. So that is now the equivalent of saying to the violinist, can't you do that in 6 minutes? And by the way, can you cover the refreshment counter? You know, it's a foolish way to spend this resource, but until we get these kinds of things straightened out, I think we'll be still thinking about how we deal with the cost disease, with a general way of dealing with the cost disease being some support. Now, when you have something like symphony, health, education, and you're dealing with this cost disease subject, where you want to approach it is the efficiencies of removing friction. And it's been estimated that about a third of our $3.4 trillion spend is administrative inefficiencies. There are lots of examples of that. So, for example, if a physician might have 8 different kinds of contracts for patients, and say one of those is a type of contract that comes in 5 varieties. So it multiplies, and each contract requires different data elements to be reported, and you don't really get any improvement in quality or quality for that. So getting some of the friction out of the system and trying to recapture a third of that 3.4 trillion, I think, is a place to expend a lot of effort.
Anything to add, Maurice?
I think it was well said. I would just add to what Eric was sharing there is that, when you go under the next level underneath the partisan divide, is the big question is, I don't personally feel that it's not that either side wants healthcare to advance or that the American populace to have healthcare. Next set of questions are who pays for it, how much, and what does it look like? And that's where you start to get the conversations to vary in a very, very strange way. And so until we start having rich dialogue on what I call the subterranean conversation, it's going to be very tough for a while.
So we're going to ask the big question. Let's talk about universal coverage. What are the benefits? Who are the winners in universal coverage? And who are the losers? So, we have a big system in our country, and it occupies a lot of our economy. And if we change it, which, would be probably far down the line, but if we change it, what would happen? Who would benefit? Who would not benefit?
So much of that, Melissa, depends on how you go about providing universal coverage. And I'll just say as one example, one of the proposals or conversations out there right now Senator Bernie Sanders, notably, is somebody championing opening up Medicare to all or to more people, at least those in the gap. And I don't know if Dr. Madera would agree, but Medicare, by and large, has been a totally successful system that maintains, by most measures, that maintains many of the free market aspects of how we provide health services in this country. It enables physicians to be compensated, whether fairly or not. That's probably where he might disagree, for their services. It provides a role for health insurers to administer the program. I know Maurice's company is a big participant in the Medicare program. It's not, I mean, it's government organized, but it's not necessarily government run. It allows stakeholders of all types to continue to operate at least within the structure that we have. If, on the other hand, you're talking about something that is truly a centralized, government-organized, government-run system that does away with employer-sponsored health insurance, sets up national rates that apply across the country and don't allow for any variation, that's a different system, and one where you would have more redistribution of the pie and more winners and losers. So much of it really comes down to how you go about setting up that structure. But there are, I think the takeaway is there are systems in place, again, Medicare being one, or the ACA being another model, where you could get to 100% universal coverage, closing the gap with those who have insurance and those who don't, with what I'll characterize as modest disruption.
Yeah, I would agree with the comments about Medicare. And I have to say, we also, I think the closest we came, perhaps, to a single payer were these recent bills that were in the Senate and the House that were thrown together. We're bipartisan. We like to say good things and criticisms of everything. We actually couldn't say anything good about these bills. They were so bad. And had they passed, the result would have been so catastrophic for the country that one could imagine a single payer emerging from that. Having said that, where we are now, we have to realize that we'll stipulate first that we're in the United States, and therefore it's going to be complicated what we do. It's not going to be probably a single payer for the foreseeable future. And, we're more focused on, rather than the payment system, principles that we have. So our principles are that individuals should be covered and have access to quality care, all individuals. That we have to pay attention to our safety net programs. CHIP for the children's hospitals and our youth, has to be reinvigorated and refunded. And we don't particularly care how those principles are achieved. We simply want to achieve those. And in the meantime, working on infrastructural problems like data transmission, getting into we're very active in the digital area now because the digital area is becoming an absolute mess. The mobile apps that you can get from the Apple Store often don't measure what they purport to measure. If you read the fine print, it'll say for entertainment only. And so there are many areas where I think we can focus and improve with an eye on systemics, eye on principle, and then try to work with any legislation that emerges to help sculpt it toward those ends.
I think that's well said. I agree with that. I think the aims of universal health care are the same. We all want the same. We want our American society to have access to high quality health care. But we also want them to enjoy choice. We believe that competition also is healthy in terms of producing innovation, and also flexibility. So how do you triage or bring all of those things together? It does present the complexity that you were describing, but that debate is going to be ongoing for a while, for sure.
So Maurice, I'm going to ask you a follow-up question. We've seen that the repeal and replace efforts have failed, which gives most of us a sigh of relief unless we want a complete overhaul immediately. But the marketplaces are still struggling, right? And there can be a lot of efforts to undermine those marketplaces with lack of subsidies, lack of support from the federal government. Where are we now with those marketplaces, and what needs to be done to shore that up?
So let's go back a couple of years in terms of when the Affordable Care Act was actually put into place. So when you walk back a few years, it was new. It was new to society at large. And so a lot of the stabilizing forces had not matured yet. So federal subsidies were there, but they need to be sharpened. How people access the program need to be sharpened. And the amount of people they thought would be there, the sheer number was not there initially. So that served as a little bit of a destabilizer. That has matured over time. You've seen, unfortunately, some price increases offset by some subsidies. You've seen restructuring of the networks. And you've seen players, some, like us, have decided to stay in. We feel like we're going to work within the system to make it work. Others are less confident about the let's say, political and regulatory environment that's there that doesn't produce the confidence around the subsidies and other things that need to be there in order for this to be a workable market. So companies like ours, we feel like we have we're gonna play. Others need the greater confidence to stay there. So my belief is that all of them want to be there. They all want a better, stable, more political and regulatory environment to be there. And I'm pretty sure all of our physicians want them to be there as well. Physician partners want them to be there, but they also recognize that it needs to be a more stable environment for them as well.
Yeah, if I could jump in on that, Melissa, I think one of the real tragedies of the ACA is not that the ACA itself was imperfect. It certainly was imperfect, but the political environment, I think, really let down the ACA. And what I mean by that is that I've been in Washington doing this work for long enough to know that there's a pattern to the way Congress works or used to work and how we address at least healthcare legislation. Typically, you would have a bill that would be introduced that would do, or enacted that would make some change. And let's take the Medicare Modernization Act of 2003 as an example that set up the Medicare Part D drug benefit, a substantial expansion of Medicare, providing drug benefits to the elderly and disabled for the first time ever. That legislation was the result of a political compromise, highly imperfect, to be sure. But it was then, as it was rolled out, the shortcomings of the original bill were addressed through subsequent legislation. So that bill was enacted in 2003. There was another bill enacted in 2005, another in 2008, another in 2009, and then even in the Affordable Care Act in 2010, we were still making fixes to original shortcomings in the original Medicare Modernization Act and the Part D program. The reason I bring that up is the ACA enjoyed no such treatment. It was so politically divisive at the outset that it became just absolutely calcified. And Congress, for good or bad, couldn't touch it because of the political sensitivities around it. And virtually no legislation has been enacted in 7 years that addressed what are the obvious shortcomings of the ACA. Now, the Obama administration, in its effort to make it work, undertook some major activities and exercised its executive authorities maybe in some questionable ways. That's where you saw a lot of litigation arise, litigation that went up to the Supreme Court several times. That's why you see this whole debate over the cost-sharing subsidies at the moment because that was an effort undertaken by the Obama administration to shore up the health plans. The point is the marketplaces, the whole infrastructure around the ACA, I think could work, but Congress needs to come together in a collaborative spirit and recognize that we've learned something over the 3 years since the ACA has been enacted, and we need to address some of these shortcomings.
Yeah, and it's that absence of confidence that is causing problems, I would say, in terms of the insurance market. Because if you had the confidence that it would be there, it would be a structured program, you at least understand what it is, and you can actually design a program that you think works for the marketplace.
You know, two interrelated points around this are that one of the things that I think is often failed to be deeply enough appreciated about the Affordable Care Act is it lifted the gate for innovation, not only in creating an innovation center within Centers for Medicaid, Medicare Services, but it sent the signal that innovation in the private sector was fine. And that had been less appreciated before. Now, as a consequence of that, and as a consequence of political uncertainty, we have a lot of balls in the air in terms of, as Murray said, not knowing, what exactly is going to happen. And it kind of reminds me of a story that a friend told me, a person I met from the West who was a cowboy, and he would describe taking these herds of cattle out in the field, one place to another. And he pointed out you wanted to move at a rate that was fast to get from point A to point B, but you stopped every once in a while. And the reason you stopped is so the mothers could find their calves in a process called mothering up. And if you keep on driving the cattle, it creates an anxiety, and that's where stampede comes from. And a lot of that relates to healthcare. It is moving so fast in so many directions. We don't stop the mother up, and we just go forward, and it creates a lot of chaos in the system.
Interesting. So let's shift our conversation a little bit to cost. One of the issues in this country is just that the costs just keep going up, and we don't have rationing at the top. And it's been suggested that we won't really have real reform until we get these costs under control, both in terms of prescription drug prices, in terms of procedures, in terms of testing. Where should we be looking at cost controls, and how would that affect the system of healthcare?
To me, the first thing is transparency. It's a completely non-transparent system in cost in virtually every way. Drugs, institutions, what supplies cost. And I'll give you an example. When I was running a health center, you could take a operating room, same surgeon, 5 consecutive patients, all of whom needed new hips. Same surgeon, same hospital, same procedure, same replacement, and they would be completely different financial transactions. There would be one financial transaction, the Blues had the best deal because they had more market share. Then it was Aetna, then it would go down, then it was Medicare, then it was Medicaid. The uninsured. Everything is a completely different financial structure. None of it is transparent. And so it's hard to address a cost system when you don't understand the financial flows within the system.
I think transparency is indeed a big part of it. This goes to healthcare is complicated. There's many ways to approach this. I think another aspect, though, is the incentives, and where there are incentives to control costs. In one place, to be sure, physicians and other providers have incentives to provide care because historically we've had a system that is based on fee-for-service. That's transforming right now. A big problem, though, also lies in, again, how we insure people in this country, and that generally people with insurance are disconnected from their own expenditures on healthcare. And when you're faced with a healthcare problem, not surprisingly, you want to solve that problem and spare no expense. And when you are not beholden to those expenses, then it's easy to say spare no expense. And of course, insurers try to be the intermediary there and try to manage that, particularly when they're responsible. But it's also a problem of misaligned, misplaced incentives in this country. I think, you said in the introduction, Melissa, that the Affordable Care Act was about trying to cover the uninsured and improve quality. It was also, I think, marketed as trying to control costs. And I used to say when I would give talks in 2010, 2011, in the aftermath of the ACA, that it had those 3 objectives and achieved on 2. That if you thought covering the uninsured was politically difficult, which really was the major focus of the ACA, and obviously we know that was extremely politically contentious, try tackling cost control. And it really fell short on that measure in terms of cost control. To be fair, it had some provisions in it that started to get at this question of incentives that I'm talking about, but did relatively little. And that's where I think as a country we're going to need to go next if we're going to get our arms around costs.
I think we've covered it all. Who knew, right? It's highly complicated, as we all described here. But it's, all of these concepts, transparency, reducing friction in the system, as you said, it's 15% of our GDP, $3 trillion. Consumer behavior, employer choice, all of those things are components that go into the cost decision. How it's financed. It is just, it is no simple solution in this, the way it's organized. But I think in terms of long-term stability of it, we're gonna have to think about how it's delivered, where it's delivered, and at what time is it delivered, are gonna be the 3 dimensions in which you look at this. But all of those are gonna be rich debate underneath them.
Could I just say one thing about incentives? Because I agree that I think we've gotten incentives all wrong, but in a very different way. When incentives were introduced in the healthcare system, it was at a time when classical economics dominated. Milton Friedman, the rational man, that everyone makes their choices economically rational, in a rational way. Does anyone in this room believe that we all make our choices in the most rational way? And coming on the heels of this was, of course, behavioral economics, where it was demonstrated that we have many, many biases that affect us. And so there was another field introduced in psychology around motivation. So a field that's probably a quarter century old, it's become quite sophisticated. And what's been recognized is you have intrinsic and extrinsic motivations. And if you take complex cognitive tasks, groups that do complex cognitive things, what you find is intrinsic motivation is much more important than extrinsic motivation. And if you forget about the intrinsic motivators, you can actually foul up the system trying to add extrinsics on. We did a multi-market study with collaboration with Rand Health to look at what the motivators of physicians were. And what we found is in practice, in different geographies, different types of practices, the number 1, 2, and 3, above everything else, the motivation was time with patients. And that was far above things like money. People in the money area wanted stability and predictability like anyone would. But the intrinsic motivator was why people went to medical school, to spend time with patients. And I've told you how physicians currently spend their time, mostly as clerks and data entry clerks. And so, Jonathan, in the American Economic Review 2 summers ago, there was a paper from Wharton where took 2 groups of cardiovascular surgeons. And in one group, told this group that if you improve this quality measure, and I think it was, readmission, something like that, we will give you an economic incentive. In the other group, they didn't even mention anything about quality or measures or an economic incentive. They said, what do you think you need to practice medicine better? And the answer was real-time feedback of data that's comparative. So they gave this group real-time data feedback that was comparative, this group the economic incentive to improve the quality measure. The group that didn't even know about the quality measure increased that quality measure 4 times that with the economic incentive. So incentives are important. Unfortunately, we have them completely wrong.
So again, how do we change the conversation?
I'm sorry?
How do we change the conversation?
Well, this is a difficult one because it's embedded. Once these policies sort of get embedded and the views get embedded, they're almost impossible to deal with. So one way of dealing with this is kind of 2 workarounds. One is to try to take the measurements down to a meaningful a number of measurements. And then if they're meaningful, meaning they actually do predict quality outcomes for patients, you can sell that to physicians because it gives them the result that they want. Right now, the data that's being sprayed around the healthcare system is, three-quarters, half of it is junk. And as we get more and more digitally skilled, we now have junk at the speed of light.
So I have a bunch more questions, but I think what I'd like to do is open it up to the audience and give you an opportunity to ask our panelists what you would like to hear about. And there are microphones coming to you.
Thank you. I'm Alicia Dale. I'm a RU alum, so I'm excited to be here. Thank you. The panel's been fascinating, and I'm hanging on your every word. A couple things you talked about was the lack of transparency, which really made so much sense in the pricing scheme. And as a business person, that's really hard to get. And I joke with my friends that when I go to the doctor, I feel like I should have my cash in an envelope and ask, for a discount. And unfortunately, it sometimes works. But I wonder, what do you think the reluctance is when there are hard dollar cost savings to be had?
I'm sorry, I missed one of the words. Hard dollar cost savings to be had?
Hard dollars. So hard dollar versus soft dollar, like real money, by increasing these efficiencies. I mean, I can take that cash home.
Absolutely.
What are the reluctances? That's my challenge when I look at the system.
So the areas that I mentioned, administrative complexity, it's been estimated about $800 billion that is unnecessary there. That's a frictional cost. If we look at the lack of data liquidity costs, one image at one person, at one institution, doesn't get effortlessly transported to another institution. You go for a consultation, you get another image. You show up at these places. It's like you're a patient that's never been seen before by anyone, which the record shows because there's no data movement. Organization of data, so it's data needed at the clinical, at the point of clinical care. Our electronic medical records came out of administrative platforms that were built for claims and billing. And so what we now have are things that are great for claims and billing and risk mitigation, but really bad for data entry and data extraction needed at the point of care. So these are all frictional costs that are enormous in the system.
Exactly, and I understand that they are enormous, and I understand that, but I'm curious to know what's the root cause, like what's the barrier of not taking a look at that, like something as simple as, like very simple billing. I know we can look at it in a very complex way, but what is the what is the reluctance to kind of look at the dollars that we're tripping over?
So one of the things I'll use, I'll use data flow as an example. We've stepped into that simply to be a Switzerland and an honest broker that doesn't have a corporate point of view but wants to present a platform. This is coming out of our Silicon Valley unit, and the idea there is to create something that's similar to the SWIFT system for currency exchange. Secure only healthcare data with healthcare standards, and recognizing that you have to bring corporate America along into that, but you can do a business model that works. So for example, you can have a cheap utility for data liquidity, but then on that backbone have value-added units that are important for, say, pharmaceutical firms. And the data model and the value-added peripheral units can drive the business model so it's cheap nationally. But these are huge projects, but we have to get out of this state of fragmentation. I think that's the killer right now, particularly when we have chronic disease. We've done that with heart disease. We've done that with diabetes. The emerging literature in cancer would suggest that for most common cancers, we're not going to cure. We're going to convert to treatable chronic disease. So we're going to have more chronic disease, not less. And we can't do that and handle that efficiently in a fragmented, non-connected system.
Thank you. I appreciate your thoughtful answers.
I guess I'd like to respond to that as well. I think to get to the very root of it is we're looking at competing values that we all possess as Americans, right? So we want a free market system. We want unlimited access to the best healthcare available. But in order to get that best healthcare, we need government controls, which we shy away from. So we end up with this fragmented system. And I don't know that it's even partisan. It's not even divided by party, because I think within each of us, we espouse those values in different ways. And so to get those controls in place and to actually have a system that works across different companies, across different insurers, with different providers is very, very difficult in this country.
Yes, hello, my name is Jakey Seisel, and I'm from England, and we have the National Health, which I have to say I love. I absolutely believe we should have something like that here. My question is, in the last 4 years, we're self-insured, and our insurance has gone up over 150%. It's not sustainable. What are we going to do? I mean, what are we going to do if it keeps going up, that kind of raises every year? How are people going to be able to afford insurance?
Well, I'll jump into that. First, I'll say with respect to national health, one of the things I said at the outset is that we don't really truly have a system here, and if we were to start all over again, we might look at England, we might look at Germany, we might look at Japan, the Scandinavian countries, some of those countries that do have more organized systems that seem to operate more efficiently and lead to those lower costs that Melissa talked about in her introduction. Nonetheless, we have the system we have, and short of just wiping it out and starting all over again, which would be hugely disruptive, and I don't think anybody desires, we have to try to turn the dials, as it were, to make the system that we have a little bit better. One of the problems, of course, is not only the rising cost of healthcare, but the burden that imposes on individuals. The ACA certainly had some measures in it that tried, in its effort to make insurance more universally available, had subsidies to people who were in certain income brackets that would increase as the cost of care increased. You're seeing that right now, in fact, as insurance premiums are rising for those who get subsidies. The role of the federal government, the burden on the federal government is increasing. I think that's one of the ironies of what Republicans are trying to do right now as they are debating the cost-sharing subsidies. They're ultimately imposing an even bigger burden on the federal government in terms of premium support, but that's a different debate. But for those in the middle who don't qualify for federal subsidies, then we are bearing this substantial burden with rising insurance costs. And again, this is where we have to, as a country, try to figure out how is it that we can contain those rising costs.
I would add to that we, have to think about prevention as well. So although our costs are much higher than the other OECD countries, if you look at the other OECD countries' cost rise per year in excess of GDP, it's always in excess of GDP. So we are highest, but the other countries have the same trajectory. If you look at things like the Affordable Care Act that was thought to maybe stop this, the degree to which the cost was higher than the GDP increment, what you find, there's arguments for and against that, but I have to say if you look at the increment of healthcare cost above GDP, you get a cyclic kind of motion over the last 30 years, and the down cycle always corresponds with a recession. So if that's the case, and we have a system that is showing unsustainability both here in Europe and Japan because of this excess in healthcare increment, I think one has to start thinking about prevention in a serious way. We, in our diabetes prevention program, we've taken that through scoring. It scored positively, meaning the cost of the program would be less than the cost of not having the program in terms of health. And we worked with the Congress, and starting in January of 2018, Medicare will reimburse for diabetes prevention programs. And that is a huge thing because we've had screening procedures to detect and early disease and prevent diseases like colon cancer from happening by doing colonoscopies and removing polyps. We've had vaccines, but we've never before, as a federal government, reimbursed to prevent chronic disease. And if we do that, then we also think of the economics quite differently. So an economist currently, I think many economists would take the view that you don't you don't save costs by prevention because ultimately someone gets sick. Ultimately there's a high cost. But that means that view only holds if you're looking at the $3 trillion cost bubble. But if you're also looking at the productivity bubble, now you're looking at the whole $18.5 trillion GDP. And healthcare is something where you look at the cost without the revenue. Most other things, we look at cost and revenue, and we can translate increased productivity into revenue. And so I think that if we get to a point where we can think more seriously in this country about preventing chronic disease, we can take a very different view of this and hopefully do something with the cost.
Hi. My question is, I thought Mr. Zimmerman did a really good job of explaining why Medicare for All, had pluses for a lot of different players, and it's a framework, seems to me, that we could move forward on. So my question is really more direct: why not? I mean, if it it does have so many advantages for so many different players, and it does on the whole, although it has problems that need to be fixed, why not start with that and work that as a framework and move forward from there?
Eric said he wants to take that question. Yeah, Eric, why not?
Well, again, the topic of the program is it's complicated, but the answer to that is fairly simple, actually, and that's cost. Who's going to bear that burden? The Medicare program right now costs, I think, roughly $650 billion to the federal government. Medicaid is just a little bit behind that, at, if I remember correctly, about $540 billion. The ACA was a $1 trillion bill expanding Medicaid and setting up the exchanges and providing all the subsidies. Those are costs that have to be borne by the taxpayer. So yes, I think there are a lot of positives that could come from expanding Medicare out to fill in some of those gaps, or maybe even to replace an employer-sponsored system of providing insurance. But somebody's got to pay for it, and that would fall to all of us.
I'm wondering, we're talking about costs, and I'm obviously of the Medicare generation, and I have seen what's happening with healthcare really since the 80s and HMOs or whatever they were. Now I see corporations owning hospitals. I see corporations buying doctor practices. I see young people, 40 is the person I'm actually referring to, an outstanding doctor, and he had to start charging $2,000 a year for, I've forgotten the word they use, for these practices. And really the cost nobody has talked about is the cost of, and you might not like the word, it's not politically correct, bribing senators, bribing congressmen, bribing our politicians. If we took that out of the system, all these ads on TV, instead of talking about keeping health care from the chronically ill, and I love the talk of prevention, which is out of the question for a lot of people, what about taking out those costs? Those are costs that don't exist with a social system, a national healthcare system. My sister and her family live in Canada. My niece just had 10 hours of surgery 3 years ago. Tremendous amount, and it wasn't malignant. Tremendous amount of care since. Hasn't cost them a penny. My nieces can go from job to job. They can do what they like. They can volunteer if that's what they want to do, if they have the money. Their health care goes with them. And I mean, the cost of medication in this country is outrageous, outrageous. And with the Part D, I mean, I remember when that went through, and there was no control on what the pharmacies could cost, to say nothing of all the lies we're told about the side effects, and not told, lying by omission a lot. So I feel like you're all being politically correct, and you're much younger than me, so you really have to be. But I was a school social worker in poor areas, and I saw kids who, first of all, they got their own breakfast and dinner because both parents had to work. And secondly, there was no money for health insurance. There was no money for health care.
So
I'm very sad and angry about what's going on in this country. And I don't know what to do with it. I feel like I can call my senators all I want. I mean, call Mark Kirk, where his health insurance saved his life. And he voted against it for the rest of us. And okay, we have to be politically correct. We're going to be so politically correct that we're going to destroy.
So let's let the panelists
country.
answer your question. So what about the costs, those unnamed costs of advertising, of lobbying?
I mean, they are part of the system. You know, I think it would be the belief of, I mean, they are costly. I think it would be the belief of anyone who's advertising, and it's really trying to, the other argument, they were trying to expand innovation, trying to gain access to their products and services. So there's an offset to that. But they are, you know, she's right. They are part of the overall cost of the healthcare system. There's a I think this kind of goes under the big narrative that he was putting forth here, is that there are places in the healthcare system where there's either just fat, there's redundancy, that actually are just increasing the overall cost of delivering healthcare. And I think that what we're feeling is that the consumer is feeling the pressure of that. But also the doctors are feeling the pressures of that. But you said it best, that if you're going to insure more people, and you're not going to have, talked about your pyramid, the rationing of services, and we have our American values, we want it when we want it, how we want it, there's going to be an expensive system to reconcile. And the sad part about that is that it comes out at the cost of the consumers.
Hi. Question about the role of the doctor-patient relationship. You know, ages ago, they used to show up at your house. They're not going to do that anymore. But I've got a guy I've seen for 30 years. We've grown old together. And I trust what he tells me to do on, anything. What role will those types of doctors play in this? Because you can get as efficient as you want, but the relationships are very important as well.
Yeah, the role of the doctor-patient relationship has been sort of a bit sacred in the history of the American Medical Association. I have to say, I gave a talk at the Japanese Health Ministry a couple of years ago, and they have a very different system where you just rotate, you see anyone. And the lack of that relationship could be felt in talking to folks, both patients and physicians. We want to create tools and resources so that this time that physicians currently spend data entry can be placed back in front of patients for that patient-physician relationship. And, I was once told that relationship is going to be less important with millennials because they have sort of a different view of the world. And a person who was a famous psychologist said at this, when we were talking about this, said, well, yes, but that's only because they aren't sick yet. And I think historically that's been certainly true in our society. And, we also have to make sure that physicians have the right placement. And what I mean by that is, I'm disturbed by things such as the states that would allow physicians to participate in suicides. I would hope that no physician would do that. One can imagine instances where you can personally think that would be advisable, but remember all the other patients and citizens are watching that too. And you have to do, I think, what you can to protect that relationship.
Melissa, can I have I think we're short on time, but can I have a final word?
Absolutely.
I would like that.
He's a lawyer.
I want to try, yes, right. It's important I speak last. I want to try to maybe bring it back to the beginning and also maybe leave us on an upbeat note, because we've spent a lot of time picking apart the healthcare system, and to be sure it's flawed. And we focused on a number of the shortcomings here, which are true. But to that person's question and comment a moment ago, I think it's really important to maintain not only context, but historic context, and think about how much progress we as a country have made and continue to make. If you look back just 60 years, we didn't have Medicare, we didn't have Medicaid. 10 years, we didn't have the Affordable Care Act. We had a growing uninsured population in this country who, we talk about the American dream, who could not fulfill on the American dream if you believe that access to health care is essential to achieving on that. We have brought in this country the uninsured population down to 10%, and that varies by state, of course, depending on whether the state has expanded Medicaid. In Illinois, it's down to 6%. That's remarkable, remarkable. So there's a lot of progress. Now, that progress comes with problems. We have to figure out how to continue to close the gap. We have to figure out how to pay for this. We got to get our arms around rising costs. But I think it's important to remember that we really are, as a nation, making a lot of progress toward enabling us to fulfill on that dream.
That was the last word. Could I add a footnote? Just a piece.
Well, I'm going to want to speak after you.
Just a piece of data to back this up. In the year 1900, of successfully delivered American babies, the death rate at 1 year of age was 16%. In the year 2000, a century later, after successful delivery, the age at which 16% of Americans were dead was 61, a 60-year difference in that century.
Yeah, good point. So hopefully everybody will go away from here a little happier.
Well, thank you to all of you for attending, and thank you again to our panelists. I really enjoyed our discussion. I think it was very enlightening, and your different perspectives were very informed and helpful. So anyone who has further questions, the panelists will be here for a few moments. Otherwise, we're done. Thank you.